Imagine, for a moment, this incredible, relentless orchestra inside your body. It's not just playing music, it's driving every single moment of your life. We're talking, of course, about the heart. Healthy heart. It plays this steady, rhythmic, almost comforting beat. Thump, 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 thump. But what happens when that symphony gets, well, chaotic? When the rhythm really goes wild? Today on the Deep Dive, we're jumping right into that complex world of cardiac rhythms. We'll explore what goes wrong and, the surprising sophisticated treatments out there to get that rhythm back in line. We've basically taken a whole stack of medical sources, research, our notes, and we've distilled it all down for you to give you that shortcut to being really well informed on this. It's crucial stuff.
Exactly. And we're not just throwing medical jargon around. The goal is to really get to the core insights, those aha moments that make sense of it all, because this really matters to everyone. You'll find some surprising facts, key differences. It'll click.
Okay, let's get into it. To understand when things go wrong, we first need to appreciate the heart's own electrical system. It's like this natural orchestra, right? It's got its own conductor, its own traffic controller.
Precisely. The conductor is the SA node, the sinoatrial node. That's your heart's natural pacemaker. It sends out the electrical signals. They spread across the top chambers, the atria, makes them contract. And that electrical activity, that's the P wave you see on an ECG.
Got it. P wave, top chambers contracting. Then what?
Then the signal hits the AV node, the atrioventricular node. Think of that as the traffic controller. Its job is to pause that signal just for a fraction of a second. Really important. It lets the lower chambers, the ventricles, fill up with blood properly. After that tiny pause, then it sends the signal down, making the ventricles contract, pumping blood out. That big, powerful contraction, that's the QRS complex on the ECG.
Ah, okay. So that P wave, then the pause, and the QRS, that's the normal healthy sequence.
That's the healthy sequence. That precise timing is key for an efficient heartbeat.
But sometimes, like we said, that rhythm goes off. We hear about tachycardia. That's too fast, right? Over 100 beats per minute.
Typically, yeah.
And bradycardia. Too slow. Under 60.
Correct.
So, okay, let's say a heart rhythm does go wild. How do doctors even start to figure out what's happening? What are the first steps?
Well, the absolute crucial first questions are always, is there a pulse? And, just as important, is the patient hemodynamically stable or unstable?
Stable versus unstable. That sounds like a really critical dividing line.
It absolutely is. It dictates everything that happens next in an emergency. If a patient is unstable, showing signs like really low blood pressure, confusion, maybe chest pain, signs their organs aren't getting enough blood, it means that bad rhythm is causing life-threatening problems right now.
Okay, so instability means immediate action.
Immediate, often life-saving interventions. Things like synchronized cardioversion. That's delivering a controlled electrical shock to try and reset the heart's rhythm. Now, if there's no pulse at all, like in pulseless ventricular tachycardia or VT or ventricular fibrillation, VF, then it's immediate CPR and defibrillation. That's an unsynchronized shock.
Got it. So the pulse and the stability, those are the immediate decision points.
They determine the urgency and the type of intervention needed. It's fundamental.
Makes total sense. Okay, so once we know if it's urgent, stable, or unstable, how do we actually treat these rhythms, maybe less emergently or long-term? We've got these medication classes, right? 4 main ones plus another. Our sources had a mnemonic, something about basketball. Nets play in BK for the championship.
Yes. That's one way to remember them. NPBKC for the drug classes. Basically, these classes are like a pharmacological toolbox, very specialized tools. They mostly work by changing how ions, tiny charged particles like sodium, potassium, calcium, move in and out of the heart muscle cells.
Ions.
Think of heart cells like tiny batteries. For them to fire, these ions have to move through little gates or channels. These drugs manipulate those gates. They control how fast or slow the charges move, which changes how the heart beats.
Okay, let's start with class 1, the sodium channel blockers. The heart's quick electrical switch, maybe.
Good analogy. They primarily decrease how quickly sodium gets into the cells. Sodium influx is what starts that initial electrical spark, the depolarization, that makes the muscle contract. So these drugs slow that down.
And there are subtypes here, too.
Right. Class 1A drugs, things like procainamide, quinidine, they slow down that electrical conduction speed, and they also make the heart take longer to sort of recharge, repolarize. They're useful for arrhythmias in both the upper and lower chambers, even specific things like Wolff-Parkinson-White syndrome.
Interesting. But powerful drugs often have downsides.
Always a consideration. For example, procainamide can rarely cause a drug-induced lupus-like syndrome. And quinidine can actually increase the toxicity of digoxin, another common heart med. That's a really key interaction to watch for.
Wow, okay. Important details. What about class 1B?
Like lidocaine, that one's a bit different. It actually shortens the recharging time, the repolarization. It tends to be most useful in ventricular tissue that's already damaged, like after a heart attack. Helps stabilize those erratic beats.
And 1C, flecainide, propafenone.
Yep. These significantly slow down the conduction speed, that electrical signal travel time. But they don't really change the duration of the whole electrical impulse, the action potential.
Okay, but here's something that jumped out from the sources. These class 1C drugs, they're apparently rarely used.
hmm
That seems counterintuitive for something that affects conduction so much. Why is that? What's the core lesson there?
That's a really important point. The fundamental insight is that sometimes a drug designed to fix a rhythm can actually cause new dangerous rhythms. It's called proarrhythmia. And this risk is much higher with class 1C drugs, especially in people who already have structural heart disease or a history of a heart attack. For those patients, the risk just outweighs the benefit. It really highlights why treatment has to be individualized. No one size fits all.
That makes a lot of sense. Risk versus benefit, always. Okay, so that's class 1. Moving on to class 2, you called them the heart's chill pills, the beta blockers.
Huh. Yes, this is a good way to think about them. Beta blockers basically block the effects of adrenaline on the heart. They decrease conduction through both the SA node, the pacemaker, and the AV node, the traffic controller. They just slow things down. So they're primarily used for rate control.
Rate control meaning just slowing a fast beat, not necessarily fixing the underlying irregular rhythm.
Exactly. Like in atrial fibrillation or atrial flutter. Slowing the rate down can make a huge difference in symptoms and heart function. They're also really important after a heart attack. And a little fun fact, or maybe a critical one, if someone overdoses on beta blockers, glucagon is the antidote.
Good to know. All right, class 3, potassium channel blockers.
Right. These work by blocking potassium from leaving the heart cells. This prolongs the whole electrical impulse, the action potential, and increases the refractory period, the time the cell needs before it can fire again.
And the big one here seems to be amiodarone. Our sources say it's class 3, but it acts like all the classes. That sounds incredibly versatile.
It really is. Amiodarone is a bit of a powerhouse drug. It has properties of class 1, 2, 3, and 4. That makes it useful for a very wide range of arrhythmias, both atrial and ventricular, even tough cases of SVT. And it has a unique role for rate control in AFib, particularly when someone also has heart failure, where other drugs might be risky.
But there's always a but with powerful drugs, isn't there?
There often is. With amiodarone, the big but is the potential for significant long-term side effects. We're talking things like pulmonary fibrosis, thyroid problems because it contains iodine, liver issues, corneal deposits, sometimes even a blue-green skin discoloration. So while it's very effective, it requires really careful, regular monitoring. Lung function tests, thyroid tests, liver tests, eye exams, usually every 6 months.
Wow, definitely a trade-off to manage carefully. Okay, class 4.
Class 4 are the non-dihydropyridine calcium channel blockers. Think verapamil and diltiazem. Like beta blockers, these also slow down conduction through the SA and AV nodes by affecting calcium movement. So again, primarily used for rate control in atrial arrhythmias like AFib, flutter, and also for PSVT.
And finally, that other category, class V, just digoxin.
Primarily digoxin, yes. It's kind of in its own league. Its mechanism is different. It's a positive inotrope.
Meaning it makes the heart muscle contract more strongly?
Exactly, boosts the pumping power. But it's also a negative chronotrope and dramatrope.
Right.
Which means it slows the heart rate and slows conduction through the AV node. So you see it used in AFib, often for rate control, and also in certain types of heart failure.
Okay, so we've got all these tools, rhythm control drugs like class 1 and 3rd, trying to get back to normal rhythm, and rate control drugs like class 2 and IV, just trying to slow things down. What's the big picture strategy?
It really depends on the specific arrhythmia, the patient's symptoms, their overall health, how long they've had the arrhythmia. Sometimes, trying to force the heart back into a normal rhythm with class 1 or 3 drugs carries risks, like we discussed with proarrhythmia. In many cases, especially with long-standing AFib, just controlling the rate with class 2 or 3 drugs, making sure the heart isn't beating too fast, is a safer and equally effective strategy for improving quality of life and preventing complications like heart failure. So it's a constant balance. Rhythm control versus rate control.
Got it. Okay. We have the tools, we understand the strategies, now let's apply them. Let's walk through some specific arrhythmias and how these tools are used, maybe starting with those really fast ones from the upper chambers, SVTs, supraventricular tachycardias. People often feel palpitations, maybe get dizzy.
Very common symptoms. And often, the underlying mechanism is re-entry. That's where the electrical impulse gets stuck in a loop, going round and round in the upper part of the heart, causing rapid beats. How we treat it initially often depends on the ECG, specifically whether the QRS complex is narrow or wide, and if the patient is stable.
Right, stable first. So for stable, narrow QRS SVT.
First line is often simple vagal maneuvers, things like bearing down like you're having a bowel movement, or a gentle carotid sinus massage in the neck. These can sometimes stimulate the vagus nerve and slow down the heart, breaking the reentry circuit.
Simple, but sometimes effective. And if that doesn't work,
Then IV adenosine is usually the next step. It works very quickly to block conduction through the AV node, often stopping the SVT right in its tracks.
and that's the one with the super short half-life, right? Less than 10 seconds.
Incredibly short. You have to push it fast, followed immediately by a saline flush to get it to the heart before it breaks down. It works fast. It's gone fast.
Okay. Now, what about Wolf Parkinson White, WPW? You mentioned it earlier. It adds a twist with that accessory pathway.
It does. WPW involves an extra electrical connection, a shortcut, between the atria and ventricles that bypasses the normal AV node delay. This pre-excites the ventricles. On the ECG, you see a very specific pattern, a short PR interval, a wide QRS complex, and this characteristic slurring on the upstroke of the QRS called a delta wave.
Delta wave, okay. And this is where things get tricky with medications, especially if someone with WPW also develops AFib.
Extremely tricky and potentially dangerous. This is a critical aha moment. If someone has WPW and goes into AFib, their ventricles are getting bombarded with rapid signals coming down both the normal pathway and that fast accessory pathway. If you give them the standard AV nodal blockers, adenosine, beta blockers, calcium channel blockers, even digoxin, you block the normal path.
Forcing all those rapid signals down the faster accessory pathway.
Exactly, which can lead to an incredibly fast, life-threatening ventricular rate, potentially triggering VFib. So, in that specific situation, wide complex tachycardia in known WPW, especially with AFib, those common drugs are contraindicated. Procainamide, one of those class 1A drugs, is often the preferred agent because it slows conduction in the accessory pathway too.
Wow. That's a crucial distinction. Knowing the underlying wiring changes everything.
Yep.
Okay, let's shift to maybe the most common chronic ones, atrial fibrillation and atrial flutter.
Right. AFib, as you said, is the most common chronic arrhythmia. It's caused by multiple chaotic electrical foci firing off randomly in the atria. The rhythm is classically irregular, no pattern to the randomness.
Just all over the place.
Pretty much. Atrial flutter is a bit different. It usually involves a single large reentrant circuit, typically in the right atrium. This creates a more organized but still fast atrial activity, often resulting in a characteristic sawtooth pattern on the ECG.
Sawtooth waves. Okay. Now, connecting this back. Beyond just palpitations or feeling tired, what's the big overarching concern with both AFib and flutter?
The biggest concern, by far, is the risk of stroke. When the atria are quivering or fluttering instead of contracting properly, blood can pool and form clots, usually in a little pouch called the left atrial appendage. If a piece of that clot breaks off, it can travel through the bloodstream to the brain, causing a stroke, or elsewhere in the body, causing a systemic embolism.
So preventing clots is paramount. How is that risk assessed?
We use a scoring system called the CHA2DS2 VOS score. It's quite standard. It takes into account factors like congestive heart failure, hypertension, age, especially over 65 or 75, diabetes, previous stroke or TIA, vascular disease, and sex category. Female sex scores a point. Based on the score, we can estimate the patient's yearly risk of stroke and decide if they need long-term anticoagulation blood thinners.
And the choice of blood thinner, you mentioned DOACs are often preferred now?
Yes. The direct oral anticoagulants drugs like apixaban, rivaroxaban, dabigatran, and edoxaban are generally preferred over the older drug, warfarin, for most patients. Studies show they have similar or even slightly lower rates of major bleeding compared to warfarin, potentially a lower risk of ischemic stroke, and they're much more convenient. No routine blood monitoring needed, fewer food and drug interactions.
But warfarin still has its place.
It does. It's still used in patients with severe kidney disease, those with mechanical heart valves, sometimes due to cost, or specific drug interactions.
Yeah.
But for most, DOACs are the go-to now.
Okay, that makes sense. Now, let's move to the really scary ones, the ones that can stop you in your tracks. Ventricular tachycardia, VT, and ventricular fibrillation, VF.
These are definitely life-threatening emergencies. VT is defined as 3 or more consecutive PVCs, those early beats from the ventricles, occurring at a rate over 100 BPM with a wide QRS complex. If it sustains, it can quickly lead to hemodynamic collapse or degenerate into VF. VF is even worse. It's just chaotic, ineffective electrical activity in the ventricles. The heart is essentially quivering, not pumping any blood at all.
Complete standstill of blood flow.
Exactly. Leads to sudden cardiac arrest. On the ECG, it looks like disorganized high-frequency squiddles.
And the immediate action here is non-negotiable, right?
Absolutely critical. Prompt defibrillation is the key for both VF and pulseless VT. Every minute that passes without defibrillation, the chance of survival drops significantly, something like 2 to 10% per minute.
Mm.
CPR is vital to keep blood flowing somewhat, and drugs like epinephrine and amiodarone are used as part of the resuscitation algorithm, but the shock is paramount.
Okay. Now, there's a specific type of VT with a very memorable name, torsades de pointe. Sounds like ballet.
It does. It means twisting of the points in French. It's a particular form of polymorphic VT, meaning the QRS complexes vary in shape and amplitude. On the ECG, it looks like the QRS complexes are twisting around the baseline, getting bigger than smaller, in a sort of sinusoidal pattern.
And it's linked to something called QTC prolongation and this R on T thing.
Yes. The QTC interval measures the time it takes for the ventricles to electrically recover after a beat. If this interval is too long, prolonged QTC, the heart is vulnerable. The R on T phenomenon is when a premature beat, an R wave, happens right during that vulnerable recovery period, the T wave, potentially triggering torsades. Many things can prolong the QTC, including certain medications, electrolyte imbalances like low potassium or magnesium.
And the treatment for torsades is quite specific.
Very specific and often highly effective. IV magnesium sulfate is the first-line treatment, even if magnesium levels seem normal. Of course, you also need to stop any offending drugs and correct electrolyte issues.
Magnesium, got it. And for long-term prevention after someone survives VT or VF?
Long-term management is crucial. Beta blockers are recommended for nearly all patients who've had sustained monomorphic VT. And for many high-risk patients, especially those who survived a cardiac arrest due to VTVF or have certain underlying conditions, an implantable cardioverter defibrillator, or ICD, is recommended. That's the device implanted under the skin that monitors the rhythm and can deliver a shock automatically if needed. A safety net.
Okay. So we've covered shockable rhythms like VF and pulseless VT. What about the unshockable ones, PEA and asystole?
Right. Pulseless electrical activity, or PEA, is when you see organized electrical activity on the ECG monitor could look like a normal rhythm or slow or fast. But the patient has no palpable pulse. The electricity is there, but the heart muscle isn't contracting effectively enough to generate blood flow. Asystole is simpler, complete absence of any electrical activity. Flatline.
And the key point here, why are these not treated with defibrillation?
Because defibrillation is designed to stop chaotic electrical activity, like VF, to allow the heart's natural pacemaker to hopefully take over. In asystole, there's no electrical activity to stop. In PEA, the activity is often organized, just ineffective mechanically. Shocking won't help the underlying problem.
So what do you do?
For PEA and asystole, the focus is high-quality CPR, giving medications like epinephrine and, crucially, searching for and treating reversible causes. This is where the mnemonic of the H's and T's comes in. It helps clinicians rapidly think through potential underlying issues.
The 6 H's and 6 T's?
Exactly. The H's, hypovolemia, low fluid volume, hypoxia, low oxygen, hydrogen ions, acidosis, hyperkalemia or hypokalemia, potassium issues, hypothermia, and the T's, toxins, overdoses, tamponade cardiac, tension pneumothorax, thrombosis, coronary or pulmonary embolism, tachycardia, sometimes listed often secondary, and trauma. If you can quickly identify and fix one of these, give fluids for hypovolemia, oxygen for hypoxia, drain a tamponade, you might get the pulse back. It's detective work under pressure.
Detective work, that's a good way to put it. Okay, let's transition slightly. We've talked about rhythms being too fast, too slow, or chaotic. What about when the heart's actual wiring, the conduction system itself, is faulty? Conduction blocks.
Yes, this is about problems with how the electrical signal travels through the heart, particularly through that AV node, the traffic controller. We touched on bradycardias earlier. Sinus bradycardia, a slow rate from the normal pacemaker, can be totally normal, especially in athletes. But then there's sinus node dysfunction, or sick sinus syndrome.
Sick sinus. Sounds like the pacemaker is just worn out.
Essentially, yes.
Oh.
The SA node just isn't generating impulses reliably or fast enough for the body's needs, often due to age-related fibrosis, scarring. Patients might have periods of slow heart rate, pauses, sometimes even alternating with fast rhythms. If it's causing symptoms fatigue, dizziness, fainting, the definitive treatment is usually a permanent pacemaker to take over that job.
Okay. And the AV blocks, delays between the top and bottom chambers?
Exactly. We look at the PR interval on the ECG, the time from atrial contraction to ventricular contraction, and whether any beats are dropped, meaning an atrial impulse doesn't get through to the ventricles at all. First-degree AV block isn't really a block in the sense of stopping things, it's just a consistent delay. The PR interval is longer than normal, but every single P wave is followed by a QRS. Every signal gets through, just slowly. Usually benign, needs no treatment.
Okay, just a delay. Then second degree.
Here, some signals don't get through. There are two main types, Mobitz-Fest and Mobitz-Kem. Mobitz-Fest, also called Wenckebach, has this characteristic pattern. The PR interval gets progressively longer with each beat, longer, until finally a beat is dropped completely, a P wave with no QRS after it. Then the cycle repeats.
It's like it's getting tired until it misses one.
Kind of like that, yes.
Mm.
It's often considered relatively benign, usually a block within the AV node itself, and frequently doesn't require treatment unless it causes symptoms.
Okay, but then Mobitz 2, our sources call that one by nature unstable. What's the big difference? Why is Mobitz 2 so much more concerning?
This is a critical distinction. In Mobitz 2, the PR interval is constant for the conducted beats. It doesn't lengthen. But then suddenly, unexpectedly, a P wave just isn't followed by a QRS. A beat is dropped without warning. The reason it's unstable is that the block in Mobitz 2 is usually located below the AV node in the His-Purkinje system, the wiring deeper in the ventricles. This type of block is much more likely to suddenly progress to third degree or complete heart block where no signals get through.
Ah, so Mobitz third is like a predictable stutter. Mobitz day is like a sudden, unpredictable cutoff that warns of a total outage.
That's a great analogy. Mobitz 2 is a much more serious warning sign. It demands close monitoring and often treatment with a permanent pacemaker because of that high risk of progressing to complete block. And interestingly, atropine, a drug sometimes used for bradycardia, often doesn't work or can even worsen Mobitz 2 blocks because the problem is below where atropine acts.
Got it. And third degree block is the complete outage.
Third degree, or complete AV block, means there's complete AV dissociation. The atria are doing their own thing, paced by the SA node usually, and the ventricles are doing their own thing, relying on a slower, less reliable escape rhythm originating from somewhere below the block. They're completely out of sync. This almost always causes significant symptoms because the heart rate is dangerously slow. It requires urgent intervention, usually temporary pacing, followed by a permanent pacemaker.
Okay, that covers the main blocks. Finally, just briefly, there were a couple of other intriguing ECG patterns mentioned. Early repolarization.
Ah, yes, early
Yeah.
repolarization. You see this sometimes on an ECG diffuse ST segment elevation, often concave or scooped looking, sometimes with a little notch or slur at the end of the QRS called a J-point or fishhook pattern. For a long time, it was considered completely benign, just a normal variant, especially common in young, healthy, athletic individuals, particularly males. There's some ongoing research about potential links and specific patterns, but generally it's seen as a normal finding.
Good to know. And the last one, Brugada syndrome. You said it sounds like a secret society.
Oh, it does have that ring to it. Brugada syndrome is a genetic disorder, a congenital sodium channelopathy. So a problem with those sodium channels we talked about way back with class I drugs. But this is inherited. It's more common in people of Asian descent. It's a very specific ECG pattern, typically seen in the right precordial leads, V1, V3. Looks a bit like an incomplete right bundle branch block, but with a characteristic ST elevation that's either coved or saddleback shaped.
And the really fascinating, maybe scary part.
The fascinating and crucial part is the significantly increased risk of sudden cardiac death due to ventricular fibrillation, even in people who feel completely fine, totally asymptomatic. Because of this high risk, even if a patient has the Brugada ECG pattern but no symptoms, the standard recommendation is often to implant an ICD, that internal defibrillator.
Wow. Even with no symptoms, just based on the ECG pattern and the diagnosis.
Yes, because the first symptom could tragically be fatal. The ICD provides that essential protection. It's a really striking example of using ECG patterns to identify hidden, serious risk.
What an absolutely incredible journey we've taken through the heart's whole electrical symphony, from that beautiful steady rhythm to the common skips and flutters people feel, all the way to those life-threatening electrical storms like VFib, and then diving into the specific wiring problems like heart blocks, and exploring this amazing toolbox, the medications, the pacing, the defibrillation, all designed so precisely to try and restore that balance.
It really is intricate. And hopefully this deep dive has given you, our listener, a much clearer, accessible understanding of it all. It's complex, no doubt, but grasping these core concepts gives you a real advantage in understanding your own health or the health of loved ones.
Absolutely. It makes you think, armed with this deeper understanding, how might you listen to your own body a bit differently now? Or maybe, what new questions does this raise for you about just how incredible and sometimes vulnerable the human heart really is?
Keep that curiosity going.
Yeah,
There's always more to learn about this amazing organ.
definitely. Keep exploring. Thanks for joining us on the deep dive.